C'est vraiment un plaisir et un honneur de pouvoir présenter un peu notre travail sur la
It's a pleasure for me to talk about the management of aortic emergencies. President, ladies and gentlemen,
Le programme SOS Aorte a
SOS
été
Aorta was designed to take care of all aortic emergencies 24 hours a day, 7 days a
et
week.
par urgence aortique, je veux dire
When I say aortic emergencies, I'm talking about acute aortic syndromes, complicated or symptomatic aneurysms, and traumatic aortic
les
rupture.
syndromes aortiques aigus.
The acute aortic syndrome is a huge range of pathologies. What's best known is aortic dissection, of course, but there are two other pathologies, intramural hematoma and penetrating aortic ulcer. They can evolve at any point in time and turn into an aortic dissection. That's why we now talk about an acute aortic syndrome and less an aortic dissection. You're familiar with aortic dissection. At a given point in time, there is a ripping of the intima of the aorta, hence blood goes through the wall and separates it into two segments. There's a true lumen, and then there's a false lumen, and there is an intimal tear. This is what we call an aortic dissection. The other members of the family, you have these penetrating ulcer and the intramural hematoma. You don't have a rip in the wall between the two. However, this false lumen under pressure may then create a channel into the real lumen and create a dissection. Here you have type A and type B dissections. This affects the ascending aorta or may not. That's what distinguishes between the two. This is what you see in this autopsy. When you operate on the patient, you have an aubergine-like aorta. You can see the false lumen and the real lumen here, and then you have this intimal flap between the two. You can see that in the CT. Here's the real lumen, the false lumen, the intimal flap, and look at this dissection with the real lumen of the aorta, the false lumen here, and this is the ascending aorta, which is perfectly normal. This CT shows the intimal flap, which goes into the left ventricle. It's very serious. There's a massive aortic leak. The patient was hemodynamically very unstable. Why do we talk about aortic dissection? It's not all that rare. There are 5 to 30 dissections per 1 million inhabitants a year. In the Paris area, that's about 300 dissections a year, 2,000 new cases in the US per year. And what's important, in historic series, almost half of these patients used to die before the diagnosis was established. This affects young people between the ages of 50 and 62. Once you have a dissection, there's a 1% mortality every hour. So after 2 days, half die. After a month, 9 out of 10 are dead if they haven't been operated on. What do they die of? Rupture, as you can see here. So it's a real medical and surgical emergency. And once the patient has been diagnosed, he needs to be sent straight into the operating theater. Type B doesn't affect the ascending aorta. This is not an emergency, it's more of a medical case, but it can be urgent. You need to have an ICU, an aggressive treatment to lower hypertension. If there are complications which appear, then you need emergency endovascular or surgical treatment. This is a patient with a rupture of the descending aorta. He's still alive because the clot around the aorta stopped the bleeding. Here you have another case. Here's the risk of rupture, which increases according to the diameter. In the event of rupture, there's 80 to 90% mortality. With an emergency operation, the results may change. There are 4,000 cases of rupture in the Paris area.
ou endovasculaire de l'ordre de 25 à
You
50%.
can get, you're familiar with the epidemiology. Here you have aortic rupture, fatal within a few hours. They're often polytraumatized patients that are hard to treat. I hope I've convinced you of the fact this is a real medical and surgical emergency. When it comes to caring for these patients, what kind of tools do we have? Before setting up SOS Aorta, we didn't have much, really. We didn't have a phone number for these emergencies. We didn't have a dedicated unit. We didn't have any algorithm for making decisions. We didn't have a standardized diagnosis workup or treatment. So all this led to a huge loss of time, a huge wastage of means. All sorts of useless examinations were carried out, and perhaps this led to a loss of life that could have been avoided. So 5 years ago, we set up SOS Aorta. We have a hotline which operates 24 hours a day. You have an emergency doctor that answers immediately and says, well, I'll take on the patient. There's a senior surgeon, aortic surgeon, who's available 24 hours a day. The admission center is designed specifically for these patients, for polytraumatic patients. They're used to seeing unstable patients. All these patients are sent into a dedicated cardiovascular ICU. There's triage, and we also have a multidisciplinary approach. Cardiovascular, endovascular, cardiological, neocardiovascular radiologists are available around the clock. What happens in practice? As soon as there's a suspected or confirmed aortic emergency, the emergency service calls 2555, which says, we'll take the patient. And then the surgeon is called using another dedicated line and is informed that an emergency case is coming in. The surgeon prepares the operating theater, the imaging units are warned, the patient comes in, gets a CT scan, the dissection is confirmed, and the patient is sent to the ICU or to the operating theater, or else, if it's not an aortic emergency, the patient is sent on to other forms of ICU or for other kinds of surgery. For type A, if the patient has had a CT, is stable or unstable, there's a decision-making tree. Hence, we waste no time before taking the requisite decisions. Likewise, ruptured AAA. We have treatment protocols for caring for these patients so that treatment is standard, and we also, since 2010, have a prospective registry. We also conducted an information campaign amongst emergency services, and we've handed out a lot of documentation. In 2010, 55 patients, and this activity is growing constantly. We currently stand at 200 patients approximately a year. This meets a real need in terms of the emergency services. We tried to compare the results 3 years before and 3 years after setting up SOS Aorta. We noted, of course, that there's been a significant increase in the number of patients, but above all, there's been a drop in mortality, whatever the pathology. Despite the fact that patients are older, they're often unstable, they have more neurological problems, and we're more aggressive in terms of surgical treatment. If you look at the geographic distribution of these patients, the setting up of this service has made it possible to extend this multidisciplinary service to a population which lives far further away. About 75% of patients come from outside inner Paris, and they even come from the outside region. Here's our database. We have some 1,000 patients so far. Here you have the aortic emergencies, 1/3 dissections, and the others are ruptures and other emergency cases. We looked through the 180 aortic dissections handled in SOS Aorta. You can see that 44% of the patients are sent to us directly by the emergency service without going through the hospital emergency wards. The percentage here is increasing. That's very positive. It'll enable us to reduce the time between seeing the patient and treatment, so we'll be able to save more lives. For the primary emergency services, well, 47% of the patients come from outside Paris, and they don't go through the actual emergency wards in the hospitals concerned. 60% of patients here have come from secondary emergency services outside Paris, more men than women, average age 66. So it's a working population, quite a young population. A third of the patients are unstable when they reach the hospital. They have a very low blood pressure. According to SAPS-2, the mean is 35% predicted mortality. More than 5% had cardiac arrest before they got to the hospital or just upon arrival. Some were saved despite the cardiac arrest. 23% had neurological signs which remain permanent: paraplegia, coma, convulsion, hemiplegia. 30% of patients have neurological signs when they arrive at the hospital. The results are foreseeable: 30% mortality. Other patients are sent for rehabilitation or discharged and go back home. If you analyze the mortality more in detail, in 0% of survival if there's no surgery, surgery under CPR, 100% surgery in unstable conditions, 42%, in stable patients, 15%. Now, if you look at age, even patients over the age of 80 tend to die more, but mortality is about 51%, which isn't overwhelming. Median time to surgery, 54 minutes. The hope is that we can further reduce the median time to half an hour if possible. To finish, after caring for these aortic emergencies, a multidisciplinary team of surgeons, endovascular surgeons, etc., deals with the patients, and then we go beyond that stage and provide for a specific patient care, genetic follow-up, genetic counseling, care for rare vascular disease, and likewise there's proper blood pressure management. The aim is to work with the research teams at INSERM in the hospital, and we're setting up a big aorta institute at present as well. So thank you very much for your attention. Thank you very much, and congratulations, Professor Achouh, on this wonderful series and the results you've obtained. Aortic dissection type A, concerning the ascending aorta, is almost always fatal in the space of a few hours if there is no emergency action. For type B, you use endoprotheses. Well, first of all, we use optimal medical treatment in intensive care wherever more aggressive, because we have really good endoprotheses. We have certain criteria. It's not only complicated type Bs, but depending on the diameter, depending on the real lumen, and even in complicated cases, we have some criteria which enable us to say this patient will evolve in the short or medium term. And we give them an endoprothesis and are obtaining very good results. One or two questions?
Well, I congratulate you for the excellent results, and thank you. I think one factor which you highlighted was the timing. Time to surgery, like in cases of the acute myocardial infarction, time to percutaneous intervention, that is very important. And your organization of the SOS aorta, that has helped you. In fact, in our place also, we get lots of patients with aortic dissection. Almost every day we get in our emergencies. And we have formed a team like yours. We have got a special aortic clinic for the same. But of course, we have to get much more organized. Time is the major factor in these patients. And as you said, in type B dissection, mainly it is the medical management. But then, if required, you go for the endovascular stenting in those patients. Then there are hybrid procedures also performed when there is arch of the aorta is involved in these patients. And we do hold the aortic workshops in our place, where all over India, the students come and learn about the aortic surgery, aortic emergencies. Maybe next time when we are holding, and if you give your consent, we'll invite you also. We may help. Question now, please.
Bravo.
Yeah, Professor Mishra.
Merci.
Yeah,
Thank you.
Very wonderful presentation. Very large volume of work. What is your policy in traumatic aortic dissections? Do you see some or you don't?
Well,
do they reach you or somebody else manages them?
Almost all of them have endovascular treatment now, with a time to on the prosthesis less than an hour between the time they come to the OR to the time they get the endovascular treatment. It's the same team because we are a vascular, endovascular, and cardiac surgery team in the same department. So it's the same team that takes them in charge. So since we've put SOS and aorta in place, we haven't treated surgically any of these patients. All of them have endovascular treatment because they have other injuries like head injuries, orthopedic.
Yeah, other injuries naturally would get priority if the patient is stable, and then he'll go for aortic stenting once the situation is under control.
Exactly. We start with on the prosthesis, and then we go to the other lesions of the polytraumatism.
Thank you.
Merci.
Très bien.